Welcome to the weekly series of Healthcare Seeing Google Plus Hangouts, where we sit down with the top leaders in healthcare IT. Before we begin, I want to remind those watching live you can tweet any questions you have to the account @TechGuy. And today we're excited to have Dr. Jonathan Handler, CMIO of M Modal, and a board-certified emergency physician. Before joining M Modal, Dr. Handler spent 20 years in medical informatics at academic medical centers, Microsoft, and the National Institute for Medical Informatics, where he was director of ICD-10. He has a broad range of experience with ICD-10. I'm pleased to have him here with me today.
Thanks for having me. I'm excited to be here.
Great. So to start off this conversation, I guess the first thing to start off, since we're talking ICD-10, is what's the state of ICD-10 implementations today, and are we ready?
Muted. Can you get?
Yep, you're good now.
Okay.
Sorry about that.
Well, I think the state of readiness is there's a lot of data, and I think pretty much everyone agrees that everyone's really basically very far behind. I think payers may be doing a little bit better than hospitals, which may be doing a little bit better than practices, but in general, I don't think anybody is where they're supposed to be according to most of the published schedules by CMS and all of the expert groups. And while there are individual practices, payers, and providers and hospitals that may be on track, I think they're clearly the rarity and the exception as opposed to the rule.
So
I could actually, I give you a little more data on that. It depends how deep you want to go.
Sure. I think the other thing that's interesting to discuss is there a difference between what most organizations are saying publicly and what they're really experiencing privately? I mean, I guess maybe almost like the health insurance exchanges, which said, oh yeah, we're ready, we're going forward, we're going to do this, but yet, when push came to shove, they weren't quite ready, as we saw. Is the same thing happening, where the public their public appearance is, yeah, we're ready for ICD-10, but in reality, they're not so much?
I don't think that's really the case. I actually think that we're getting pretty good data on how unready people are. I mean, there was a recent survey by the MGMA, which is a big group of medical practices, and less than 5% reported that they've made significant progress towards readiness. 33% in another survey said they haven't started at all. And 22% say they don't even know where to start, right? And these are recent surveys, so I actually think they're not over-reporting how well they're doing, or if they are, let's put it this way, they're in big trouble, because the numbers of people numbers of groups who are reporting that they've made any significant progress at all is really pretty small. I think small to mid-sized hospitals, we've seen some surveys from them. They said, well, about 20 to 40% of them say they haven't begun training for their coding staff. So we can say, well, that's good. 60 to 80% have begun it, but that's just starting. Tons of them don't know how they're going to map their claims to DRGs. About half of them haven't really begun document improvement education for their staff, and that's really where their biggest risks lie. 31% of small to medium-sized hospitals in a survey have said they're not even going to begin dual coding, which is one of the things you do to start practicing coding for ICD-10, until October of 2014. So really, basically, when the due date comes, they're going to start scrambling at that time. So I think our problem is not that people are overconfident or overestimating. I think people are realistically reporting that they're way behind.
Yeah, that's pretty scary to consider that they're not going to dual code until 2014. But let's dig into some of the areas that could be risks for these organizations, because I see a whole variety across the whole spectrum of ICD-10 that could be a challenge to that organization. For example, let's start with the EHR and the health IT systems that they use. Are they ready? and what still needs to be done so that they are ready for ICD-10?
Well, I keep getting muted.
Sorry,
that's okay. I think it's hard to tell where EHRs are. I mean, I can tell you where we are. For example, I know that our coding software, for example, is ICD-10 ready. I think there's a variety of reports out there by the vendors in terms of how far along they are, some reporting more than others. But when you look at what the practices are seeing, what the actual hospitals are seeing, you know, 50% of practices in a recent survey haven't heard from their practice management system vendor. Nearly 50% haven't heard from their EMR vendor about readiness for ICD-10. So if they're ready, I would say that the providers aren't hearing about it yet in many cases. So I do think they're clearly working on it. It's a big deal. They know their customers are depending on them for it, and I'm sure they're making lots of progress. And at the same time, I think the experience that providers are having out in the real world, and we've got a fair amount of data to show this, is that the connections at least aren't happening even if they're ready, and most likely they're not happening because there are a significant number of vendors who probably aren't where they need to be yet.
Yeah, I think it's actually significant, especially with the practice management systems. You know, some have said they aren't even going to do ICD-10. They're basically just finishing the end of life. And it'll be interesting to see how many choose to go that route. And although I bet many of them that aren't answering are going that route, but they're just not communicating it to their customers. So that could leave them in an interesting lurch, right?
Well, I think so. I mean, their revenue depends entirely upon coding, drives the entire business of healthcare. And if you're a system and your mechanism for getting paid is about to go away, and you don't know it yet, that could obviously be a big deal. You know, there are real challenges for these groups. There's a shortage of coders in the country. There's a shortage of coders who know ICD-10. It's expensive to find these people. It's expensive to hire them. It's expensive to get them trained. If you have these people, it's hard to teach them about ICD-10. We actually have an apprenticeship program where we will help train coders at an institution, and you know, to try and help this problem, and let people essentially apprentice with us. And I think it's a pretty cool program to help maybe do our part to alleviate some of the risks that people are seeing with ICD-10 in terms of training their coders, making sure that their coders and their practice management team is ready for this change. But absolutely, it puts them at humongous risk if they end up in a situation they don't expect, where suddenly they don't have a mechanism to get their stuff coded in ICD-10.
So, you know, let's talk about that a little bit more. You know, I mean, that's an interesting program to you know, do an apprenticeship to help coders. I mean, across the spectrum, do you think coders are ready? Do they have enough resources? Do we need to worry about coders getting more training, or do you think, since that's their job, that they will be ready when the time comes?
Well, it's, you know, it's hard to say. There's pretty clear evidence that coders are among the first to start getting trained at these different places, and so I know there's a lot of work happening in that. At the same time, we also know there was a pretty recent report by a group that had their coders start trying to code in ICD-10, and they found that their coders had literally a 50% loss in their productivity. It took them twice as long to code a chart in ICD-10 as it did to code ICD-9. And just as scary, or maybe more scary, their accuracy was really pretty poor. They reported something like 55% correct coding on their first round, and they did get a little bit better on their second pass, but on the second pass they didn't go up. They went up less than 10%. And you know, it's a very complicated coding system. We know that expert coders who try and code even in Snomed-CD, which is another complicated coding system, people who've been doing it for a long time, they don't get agreement in codes more than 1 out of 3 times among 3 different coders. So you give 3 coders the same chart, and you say, what SNOMED code would you assign? And even after they've been doing it for a long time, only 1 in 3 times will all 3 of those coders agree. We're going to clearly be seeing the same sorts of things with ICD-10. It's, you know, the increased, lots of the things that bring value for ICD-10, that same complexity and that same granularity, and also brings difficulty in getting agreement on what is the right code. It's going to take them a long time to do it. So they're working hard in their training, and at the same time, a lot of them may be behind on their training, and to the extent that they're doing it, what we're seeing now is a decrease in coder productivity and decrease in accuracy. Obviously, we think we have some software to help with that kind of stuff, and others may have that as well. But it's clearly going to be a challenge that we're all going to have to overcome if, assuming that ICD-10 goes forward.
So, you know, let's talk a little bit more about the coding engine. I mean, obviously you can speak to yours the best, but, you know, if there is some variation of understanding of which code should be used, doesn't that make it a challenge to create an ICD-10 coding engine? And how does your coding engine deal with that, you know, to help them deal with the complexities of understanding which one should even be used?
Well, what our coding engine does is it allows, it has a workflow that allows for quality assurance, that allows for you to, you know, creates a workflow that lets, actually one of the unique things that we have is the ability to allow coders to dual code. Instead of the coder puts in one code and then we automatically mapping to the other, which we can do. We also allow a coder who wants to practice and learn ICD-10 by dual coding, which is a recommended practice. We allow coders to actually code in our system in ICD-9 and then ICD-10, and then have it be reviewed in QA by additional experts. If 40 experts can't agree on what the right code is, then that means there is no real gold standard definition of right. But to the extent that you create a software program and a process and a workflow with the right experts involved, you can come to a consensus about what the right things are. And our goal is to try and help create workflows and processes and software to support that. That really helps that. If that makes sense.
Sure. And I guess the other question related to that is, you know, how much reliance can a coder, or I mean, I guess it's probably even the doctors that interact with the coding engine as much as the coders, how much can they rely on the coding engine, and how much of it still needs a little bit of personal human touch to make sure that the code is indeed what it should be, versus how much can they rely on the coding engine?
Well, obviously that depends upon the coding engine, and it depends upon the person and the chart and the situation. I think pretty much everyone agrees that the coding engine is there as a supplement to the person to make the person more effective, more efficient, but is not a replacement for the person. This is complex stuff, and it's just like decision support in healthcare. You know, when a computer pops up and says, we recommend considering this treatment or maybe avoiding this medication, I don't think most people are ready yet, and rightly so, because this, you know, most software is not yet better than the human being, but the human being plus the software together are better than either one alone, and that's really, I think, where the magic lies. It's really the foundation of medical informatics. That's an underlying tenet, right? A human plus a computer is better than a human alone. And I think that's really the case here as well.
And so how about doctors? You know, will they be able to rely on the coding engine, or do they need some extra training from what you're seeing? And are they getting the training if indeed they need that?
I think it's pretty clear there's a lot of data that doctors need the training. It's pretty clear that most institutions are well behind on that training. I don't think anyone really knows what training will be particularly effective or how to do the training in an effective way. It's a brand new thing, so we don't know what we don't know until we start getting out there and doing this stuff, and we know that we're already behind. So as a country, I think what's critical, and one of the things that we believe, is that we know from tons of data in pretty much every other area where they study training that when you get training, it's best to do it as close as possible in time to the point that you're actually going to use it. When you're doing training, it's critical to repeat that training over and over, because the learning decays over time, especially if you don't use it. And so, and that ICD-10 really is not so much just about the coding as it is about whether or not you get the documentation right up front and complete enough up front in order to enable the coding to happen afterwards. And so, you know, adequate, accurate, complete coding, the kind of coding that you need for ICD-10. So in order to do that, for instance, we have a number of software tools that we've put together, software products that we have that allow you during the course of documentation to get help, training, alerts, triggers that let you know when you may or may not have completely documented something, in order to help you to document more completely so that you can support ICD-10 coding downstream. Also to give you training in real time while you're actually in the process of documenting about A, what do you need to document, and B, to the extent that you're interested and you want it and it's appropriate for what you're doing, you know, what are relevant ICD-10 codes, have an infrastructure to do that in real time while the clinician is working in their EHR and documenting.
Yeah, so you know, it's interesting. You've mentioned a few times that you know we're behind the 8 ball on ICD-10, but I guess is there really any hope that ICD-10 will be delayed, or do you think that the date's final? Of course, you know, I'm asking you to look into a mirror ball, but you're looking at the trends you're seeing. Do you think there will be a delay, or do you think it's coming one way or another?
Well, obviously, I don't have a crystal ball, and the last thing I think I am is a predictor of what the government's going to do. What I can say, even just looking at recent dates, right, there's nothing you can't accomplish at the last minute when it looks like there might be a meltdown. So, so I would say nothing is ever impossible. You know, really, all of healthcare is driven around this, and so we know that everyone expects that doctors are going to be busier, not less busy, as we have the Affordable Care Act coming around and providing insurance for people who didn't have access to care before. So we actually expect doctors to be likely busier than they ever were before. But what we hear from practices is that nearly 90% of them are concerned about loss of productivity, and estimates in one survey about the loss of provider productivity range between 20 and 40%. So at a time when we have more patients coming into the system ready to get care, able to get care, suddenly we will have fewer people, fewer patients able to go through the system with the doctors that we have. So if we lose 30% productivity, and when you call your doctor to get an appointment and it's 3 months out, well, now it's 4 months out or 5 months out, depending on how much productivity loss there is. And so this is a particularly potentially painful time, let alone the massive impact on costs, which really is the thing that allows a doctor and a hospital and a payer and everybody else to stay in business. People can't work for free; they have to eat too. So, so I think what we will see is there will be push back and forth, and that the former chief of the ONC very recently said, emphasized there's no way we're going to delay ICD-10 further. What I guess we'll see as we go forward is if we're really that far behind, and if it's going to be a big impact that may be negative on patients, and if it's going to seriously disrupt the healthcare system in a way that doesn't support healthcare, we may find that maybe they will delay ICD-10. Right now they're saying no, but who knows? And we've certainly seen that the government can be unpredictable, and the one thing I would predict is that will continue to be true.
I think no one would argue with that, and I think healthcare knows government regulation and government unpredictability better than any organization, except maybe the military, I guess. So, you read a blog post a little while back that suggested that maybe we should abandon ICD-10 and go with compositional Snomed-CD. I'm not sure that's a reality, especially, like the comment you mentioned from the ONC chair that ICD-10 is coming. But, why should we use Snomed-CD rather than ICD-10? What are the benefits? And for those that don't know what Snomed-CD is, could you give them some insight into what it is and why it's better than ICD-10?
Sure. Snomed-CD has been around for a long time. It's been continuously updated, and it is a clinically relevant terminology that's much more complete than ICD-10. Doctors, according to the meaningful use mandate, are actually required to document problems in a patient's problem list in Snomed-CD. So they already are obligated to learn when they make a diagnosis and put it on a problem list. They're already obligated to deal with Snomed-CD. And that's a good thing. It's a clinically relevant, appropriate terminology. It's great for supporting research. It's great for supporting clinical care. It's great for supporting decision support. And ICD-11, which is the follow-up to the now 20-year-old ICD-10, is just around the corner. And guess what? It's based on Snomed-CD. So if I learn Snomed-CD, which I have to anyway for ICD, for meaningful use, I will just be setting myself up to know ICD-11, which is a much better, everyone expects it to be a much better terminology. And I think it will be better because it's based in Snomed-CD, and we get alignment there. What a doctor or somebody will have to do now in the healthcare system is when I make a diagnosis of diabetes, I will have to get it documented on the problem list in one terminology, which is Snomed-CD, and then redocument it and translate it again in another terminology, which is ICD-10. That terminology is 20 years old. It's got a lot of problems with it. It's going to cost us a fortune to change to ICD-10, and just around the corner is ICD-11, which is based on Snomed-CD, which we already have to use. So actually my recommendation was, let's either, between now and ICD-11, let's either use Snomed-CD, because we have to use it anyway for our problem lists. Why don't we just use that for diagnoses, for coding and billing? It's even better than ICD-10. And that simplifies things for doctors. It gives actually better data for research, better data for payers, better data in every way, and sets us up for ICD-11, which is just coming right around the corner. So, to me, I don't understand why we would make this big push, which I think pretty clearly people are behind on. It's going to slow things down. It's going to slow down doctors. It's going to reduce access of care to patients. It's going to cost the healthcare system a fortune, only to have a much better, more modern, more appropriate terminology come right around the corner. So that's why I said, hey, let's either wait for ICD-11, or if we have to do something right now, let's do Snomed-CD, because we have to do it anyway for problem lists. I don't know if I...
No, I think you explained it really well. It's almost disappointing because I'm not sure I see a path forward to that idea, as logical as it may sound. And probably one of the biggest challenges is that so many companies, I mean, including your own, have invested so much money in ICD-10 that the backlash from not going to ICD-10 would be terrible. And when government works, backlash matters, even if it's the wrong way to go.
Yeah, well, if we go forward with ICD-10, which if you are a betting person, you probably be smart to bet that ICD-10 will happen.
Yep.
We've got a lot of technology that we think can really help smooth that transition and make it better, easier, and faster for doctors, patients, payers, everybody. We think we've got something to offer there.
So definitely ICD-10 is going to be a challenge, and I think Snomed-CD offers interesting opportunities. But I guess the core question I think a lot of people are asking is, will healthcare get any value out of ICD-10? And what is the value that we'll receive from moving to this more detailed coding structure?
Yeah, well, whether we whether we move to wait for ICD-11, do Snomed-CD, or use ICD-10, all three of those options offer value beyond what ICD-9 provides today. So will healthcare get benefit? Yeah, I think they will. The big question is does the benefit outweigh the cost? But assuming that we're going to pay if we pay the cost, will we get benefit? The answer is yes. Clearly, we'll get a lot more granularity in data. Of course, I have my dog barking now. Clearly, we'll get a lot more benefit in terms of being able to do research on data that is much more granular. We'll be able to cover diseases that aren't covered today in ICD-9. We'll be able to get a whole bunch more information that will support public health research, that will support clinical research, that will allow us to do better payments and possibly, I don't know if this will really play out, but possibly reduce the number of denials that happen, because you're essentially getting like a mini medical record in a ICD-10 code. I'll believe that actually happens when I see it, but that has been something that has been offered as a potential benefit. But at a minimum, in terms of being able to get better, more granular, richer data that you can use to run your healthcare system, to run your provider system, to run your system from a public health standpoint, for medical research, all those things. I think we will get benefits out of it for sure. And it's really coming down to a question of does the benefit outweigh the cost, and if we're going to pay the cost, do we have any better options? But I do think the answer is yes, we'll get something out of this one way or the other. And our goal is, hey, if we do pay the cost, then let's do our level best to make sure that we get the most possible value that we can for the investment that we make.
Great summary of ICD-10. Thank you so much for being with me, and apologize for the technical problems, but we'll continue to improve it over time. So thank you.
I think that was probably on my end, but thank you for being gracious, and thank you for having me.
Great to have you.